This is Stephanie Huff, and I am recording another concept on intracranial regulation. This one is on increased intracranial pressure. So an overview, increased intracranial pressure is also called intracranial hypertension. It is a sustained elevated pressure of greater than 15 millimeters per mercury. Increases in intracranial pressure or intracranial pressure increases and decreases throughout the day with coughing, bending, sneezing, and straining. These all will increase intracranial pressure. These are usually brief increases in pressure, and so they are not harmful. Anytime you have a sustained increase in intracranial pressure, this results in damage to the tissues of the brain. Cerebral edema is your most frequent cause. Others include head trauma, tumors, abscesses, strokes, inflammation, and hemorrhage. Looking at the pathophysiology, the adult cranial cavity is rigid, and that's just looking at the skull. It is filled to the capacity with brain, cerebral spinal fluid, and blood. There is a dynamic equilibrium in all three of these parts. So if a volume increases in the brain, cerebral spinal fluid, or blood, the volume of the others must decrease, and so they are compensate. And this is known as the Monroe-Kelly hypothesis. So your normal intracranial pressure is 5 to 15 millimeters per mercury, and it is measured intracranially with a pressure transducer with the patient lying with the head of the bed about 30 degrees. All right, the brain does require a constant supply of oxygen and glucose to meet metabolic needs. Ischemia results if this blood flow is interrupted. You have compensatory mechanisms that occur when the blood flow decreases. The first is stretch receptors, and these are in the small blood vessels of the brain, and they cause smooth muscles of the arterioles to constrict. When stimulation decreases, this causes vasodilation. Another compensatory mechanism is chemical autoregulation. And this is can be a buildup of metabolic byproducts of cellular metabolism, like lactic acid, pyruvic acid, carbonic acid, carbon dioxide. These can cause vasodilation to increase cerebral blood flow, or it can cause vasoconstriction to decrease cerebral blood flow. Increased intracranial pressure may result from increases in contents due to space-occupying lesions, hydrocephalus, cerebral edema, which is swelling, excessive cerebral spinal fluid, or intracranial hemorrhage. Compliance is the relationship between the volume of intracranial components and intracranial pressure. Intracranial hypertension, remember that is increased intracranial pressure. It occurs when the capacity to compensate for the increased intracranial pressure is exceeded. So this is a sustained state of increased intracranial pressure. It can be life-threatening. Autoregulatory mechanisms have limited ability to maintain the cerebral blood flow. So basically the body just can't compensate anymore. Looking at etiology, it commonly results from head trauma. Other causes are going to be your hydrocephalus, cerebral edema, excessive cerebral spinal fluid, and intracranial hemorrhage, like previously discussed. Different causes throughout the lifespan. Falls are seen in infants and young kids as well as elderly. Abuse is seen in infants and young kids as well. Your preschool and school age are at risk for bicycle, swimming, or activity-related accidents that can cause increases in intracranial pressure. Your motor vehicle crashes and addictive behaviors are seen more in your adolescents and adults. The abnormal cellular growth could be from intracranial tumors. These can be either benign or malignant, and they basically compete for space in the cranial vault. Your risk factors for increased risk of trauma: medications that alter balance, perception, and reflexes. So anything that can alter their level of consciousness, making them drowsy or anything like that. So some of your, like your narcotics, anti-anxiety medications, just a couple of examples. Weakness, just because that's going to cause them to fall and potentially hit their head. Their unhealthy lifestyle choices will include drug and alcohol abuse. Also, some of your illnesses like meningitis is a risk factor. Your premature infant, they are at risk for increased intracranial pressure from intracranial hemorrhages, because this is usually secondary to fragile cranial blood vessels. So looking at prevention, you need to teach the client ways to prevent trauma, and that would be use of personal protective equipment like helmets, seat belts, avoid using the phone while driving, avoiding recreational drug use and alcohol use. Premature infant care, that is going to include avoid rough handling, providing adequate head support, and avoiding hypoxia. Your clinical manifestations. With loss of autoregulation, the intracranial pressure will continue to rise. The cerebral perfusion falls and causes tissue ischemia. Changes in cortical function are usually your early manifestations of increased intracranial pressure. You can have behavioral and personality changes. Memory and judgment becomes impaired. You may have speech pattern changes, and level of consciousness decreases. You can also have what's known as ipsilateral pupil dilation, and so you only have dilated pupil on one side of the body. But usually your changes in level of consciousness are your first signs that you'll see. So you may have some confusion or restlessness. Those may be your earliest signs that you may see. And this is just to remind you of your posturing. For your decorticate, posturing is toward the cord, decerebit is away from the cord. Looking at lifespan considerations, signs of increased intracranial pressure in children could include headaches, nausea and vomiting, dizziness or vertigo, downward deviation of the eyes, which is known as the sunsetting sign. They may have slight changes in level of consciousness and restlessness. In your infants, you will see irritability, bulging fontanelles, increase in head circumference, high-pitched shrill cry. They're usually very sensitive to touch and sound. Cushing's triad is an increase in systolic blood pressure and widened pulse pressure, bradycardia. They may also have an irregular respirations and fixed dilated pupils. In collaboration, you need to identify and treat the underlying cause, control the increased intracranial pressure to prevent a herniation syndrome, which is always bad when you have brain herniation going on. Increased in intracranial pressure is always a medical emergency. A lot of times there's little time to complete diagnostic test, and diagnosis is made based on observation and their neurological assessment. Even your subtle changes may be significant, and usually the nurses are the ones that find these because they're with the patients, taking care of them 24/7. And so that's why you have to make sure that you have good neurologic assessments and know how to do those, so that if they're not in the ICU setting and you don't have you're not being able to monitor their intracranial pressure, you're going to have to go on your physical assessment. So your diagnostic test, these are done to determine the cause of the increased intracranial pressure. So your CTs and MRIs will note any kind of space-occupying lesions or hydrocephalus. Your lumbar puncture is not performed when you have an increase in intracranial pressure, or if you suspect it, because if you start pulling off some of that cerebral spinal fluid, you can actually cause the brain to herniate. Surgeries that are done, they will done to remove a brain mass. So if it's some kind of tumor or abscess, they can use surgery to remove that and decrease the intracranial pressure. They can also do a resection of infarcted or necrotic tissue to help reduce the brain mass and reduce the intracranial pressure. Drainage catheters or shunts to drain excessive cerebral spinal fluid and help to reduce hydrocephalus are done. This is usually via a burr hole that is done into the ventricle. So your pharmacologic therapy, diuretics are commonly used. Your osmotic diuretics is mannitol, and they will help decrease the cerebral edema, which also decreases the intracranial pressure. They can also use loop diuretics such as furosemide or ethanocrinic acid. Sedation and paralysis are used to help decrease intracranial pressure. Your antipyretics such as acetaminophen helps decrease temperature, because anytime you have hyperthermia, that increases intracranial pressure. Anticonvulsants are used to manage seizures that are caused by the increased intracranial pressure. Your GI prophylaxis for stress, gastritis, and ulcers that we talked about in the concept of intracranial regulation, so that's your proton pump inhibitors and your histamine H2 antagonist. IV fluids are given to maintain fluid and electrolyte imbalance. TPN is used if they are not able to get enough in orally or enterally, or they may not be able to use enteral feedings for some reason. Your vasoactive medications are also used. Your antihypertensives like beta blockers are used if their mean arterial pressure is high. If the mean arterial pressure is low, then they use vasopressors. Some of your non-pharmacologic therapy facilitates continual assessment of intracranial pressure through ICP monitoring and mechanical ventilation. So with ICP monitoring, basic monitoring systems will include an intraventricular catheter, can also be used to drain cerebral spinal fluid if they need it, a subarachnoid bolt or screw, and an epidural probe. All three of these can be hooked up to a transducer that is hooked up then to a monitor, and they will give you tracings on the monitor, and as well as numbers that will let you know what their intracranial pressure is. A transcranial blood flow is monitored with Doppler studies to measure the velocity of the blood flow in the cerebral vessels. Your cerebral perfusion pressure, or your CPP, is the pressure it takes for the heart to provide brain with blood. It can also be calculated by subtracting your intracranial pressure from your mean arterial pressure. Your normal CPP is 70 to 95 millimeters per mercury. So these are just some of your methods of monitoring cerebral spinal fluid, as well as they can drain cerebral spinal fluid. And so this one's going into the ventricle area, and you can have some that just go right into the subarachnoid area and different areas of the brain, depending on what they're needing to monitor and if they're needing to drain any cerebral spinal fluid as well. For your intraventricular catheters, those are the ones that have a transducer with a three-way stopcock, and you'll talk about those again when you talk about hemodynamic monitoring. You'll learn how to level those. And so this is just what your waveform may look like, and so you can see how you have some normal levels and then moderate levels of elevation all the way to significant elevation. And so anything above 15, remember, is an abnormal finding. All right, and this is just showing them leveling the transducer, but like I said, you will talk about that more when you talk about hemodynamic monitoring next semester. Mechanical ventilation. Increased intracranial pressure often requires intubation and mechanical ventilation for respiratory management. it is important to maintain oxygenation. So usually the PaO2 is maintained at 100 millimeters per mercury. The PCO2 is maintained at 35 millimeters per mercury. Some of your other therapies are going to be physical therapy. They can be used to help prevent muscle atrophy. Respiratory therapy is used for ventilator management and after weaning the patient from the ventilator. Counseling is used for both the patient and the family. Hospital chaplain may also be beneficial. Looking at the nursing process, you need to identify those at risk and manage factors known to increase intracranial pressure. So the major focus is going to be to protect the patient from sudden increases in intracranial pressure or decreases in cerebral blood flow. So looking at your assessment, it is usually recommended to assess and monitor your patient every 15 to 60 minutes and as needed. This is going to include level of consciousness, which is your Glasgow Coma Scale, looking at their behavior, motor and sensory functions. So a lot of times that is assessing your spinal nerves, and so they will assess one side of the body and compare it to the other side as far as movement and sensations. Do they feel you touch in different parts of their body? Sometimes you can do soft touches with cotton balls or sharp with like a needle. Also assessing pupillary size and the reaction to light. Assessing vital signs, including their temperature, because remember, temperature, if they're hyperthermic, then that can cause increases in intracranial pressure. You also, if they do have a temperature, you need to also find out if there are other causes for the temperature besides just what's going on with them neurologically. Make sure there's no infectious process going on. Need to look for trends and sudden changes in their neurological signs. This often indicates a deterioration in their status. Monitoring their pulse oximeter and their ABGs. These are your NANDA diagnoses for increased intracranial pressure. In the planning, goals may include that the patient will maintain an ICP of less than 20 millimeters per mercury. They experience no further complications from increased intracranial pressure. They do not experience any infection from the ICP monitoring devices. They maintain adequate cerebral perfusion to prevent further cellular damage. Family members will demonstrate the ability to maintain a low stimuli environment, because that will help decrease those intracranial pressures. Implementation, you want to perform neurologic assessments as they were scheduled, making sure that they are thorough. You want to maintain an airway patency. Make sure that you are, if they are patients that are ventilated, you want to pre-oxygenate them before suctioning with 100% oxygen. Limit the suctioning to 10 seconds. Repeated suctioning will cause an increase in intracranial pressure. Making sure that you ensure an adequate ventilation. As far as positioning and moving, you want to make sure that you're maintaining an alignment of the head, and so it needs to be in a neutral position. You don't want to have it kinked to the side, so sometimes they may have to use sandbags on each side of their head to keep that head in a neutral alignment, because anything that is not neutral can increase their intracranial pressure. Also making sure that you are turning them every 2 hours so that they don't get skin breakdown, but be very careful as you're turning them. Instituting seizure precautions, since they are going to be at risk for seizures. Monitoring their fluid and electrolytes. Also monitoring ABGs. Elevating the head of the bed to 30 degrees as prescribed, and that helps decrease intracranial pressure. You want to monitor for bladder distension and bowel constipation. Both of these can increase the interthoracic pressure, which will in turn increase intracranial pressure. If your client is alert, You want to assist them in moving up the bed. Don't allow them to do it by themselves and pushing up with their heels or their arms, because all of that's going to cause them to bear down like a Valsalva, which increases intracranial pressure. You want to plan nursing care so that activities are spaced, so that if you do activities one after another, that increases intracranial pressure. You want to maintain fluid limitations if prescribed to help decrease cerebral edema. Reducing stimuli as much as possible, keeping a quiet environment, avoid jarring their bed, maintain a calm, reassuring manner. A lot of times if you can have family members come in and be with them, and just soft, gentle touch is known to decrease intracranial pressure. For your clients that have an ICP monitoring device, you want to keep the dressings over the catheter dry. Any wet dressings can harbor bacteria. You need to change the dressings on a prescribed basis, usually every 24 to 48 hours. Monitor the insertion site of those monitoring devices for any leakage of cerebral spinal fluid. You can also test it for glucose. If it's positive for glucose, then it's cerebral spinal fluid. Monitor the drainage of it, how much drainage you have. Monitor it for infection. So you're looking at changes in vital signs, if they start to develop chills, if they have increases in their white blood count, positive cultures of the drainage. Make sure that you're using aseptic technique when you're dealing with the drainage catheters and the whole equipment. Evaluation. Some of your expected outcomes may include that the client's intracranial pressure returns to acceptable limits following treatment. Their level of consciousness improves with reduction of the intracranial pressure. The client will experience no infection as a result of the intracranial pressure monitoring system. And the family will describe appropriate outcome expectations. So this is the end of increased intracranial pressure. If you have questions, let me know and I will try to help clarify.